The key takeaway message of this article is that the incidence of acute kidney injury after PCI continues to remain high at nearly 10% in the contemporary era. And there is high in-hospital mortality as well as long-term mortality associated with AKI post-PCI. Hi, I'm Vinayak Nagaraja, an interventional cardiologist at Mayo Clinic, Rochester, Minnesota. I'm also an assistant professor at our institution. I'd like to discuss our accepted article that's titled Impact of Renal Function and Acute Kidney Injury on Long-Term Outcomes Following Percutaneous Coronary Intervention, which will appear in the upcoming issue of Mayo Clinic Proceedings. We use the Mayo Clinic PCI registry, which constituted of 9,200 patients who had varying renal functions, but were not on dialysis. The overall incidence of AKI over the duration of the study, which was from January 1st, 2009 to June 30th, 2023, was nearly 9.3%. The definition of AKI was defined as increase in serum creatinine by 0.3 milligram per deciliter or 1.5 times baseline. Unfortunately, nearly 1% of the patient developed acute renal failure needing renal replacement therapy. We also observed a monotonic increase in yearly incidence of AKI over the duration of the study. The most important predictors of AKI in hospital were the use of an intracardiac balloon pump, which translates into cardiogenic shock, ST elevation, myocardial infarction, congestive heart failure, moderate severe renal impairment, type 2 diabetes, contrast volume as a continuous variable, female gender, and age. Acute kidney injury over the duration of the study was evaluated using a survival analysis, using the multivariable Cox proportional hazard regressions. We inferred from the study that AKI resulted in substantially elevated all-cause mortality with a hazard ratio of 2.16. Similarly, repeated revascularization was elevated at a hazard ratio of 1.41. Myocardial infarction and MACE rate was significantly elevated with a hazard ratio of 1.46 and 1.76 respectively. We take utmost care to prevent AKI by using thoughtful clinical judgment as well as limiting contrast dose. In addition, we also utilize biplane angiography and intravascular ultrasound. Most importantly, we use intravenous fluids in patients with advanced renal dysfunction to prevent AKI post-PCI. The findings are very relevant to our clinical practice as we are seeing a lot of sick patients on a daily basis, which have a higher rate of congestive heart failure, renal dysfunction, and type 2 diabetes in the elderly population. I think it's very crucial for us to consent our patients for AKI and hemodialysis, especially in the patients with moderate to severe renal dysfunction. The crucial next step in research would be inclusion of artificial intelligence to understand patients' risk and identify high-risk patients. We can implement interventions like hydration, minimal contrast PCI, and also use intravascular ultrasound. In addition, discontinuation of NSAIDs and ARBs are crucial peri-procedurally. We should also follow up our patients quite strictly after PCI. And we will see the rise of artificial intelligence by which we can inculcate risk scores like the Maran risk score or the multi-morbidity Mayo Clinic risk score that can extract all the variables from the electronic medical records, and therefore facilitate informed consent and also institute mitigation strategy to lower the risk of AKI. I'd like to thank you all for listening to us, and I hope you enjoy our manuscript. Thank you.
We hope that you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel, www.youtube.com Mayo Proceedings, or journal updates on Facebook, www.facebook.com Mayo Clinic Proceedings. You can also follow us on X, formerly known as Twitter, available at Mayo Proceedings. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This content is copyrighted by Mayo Foundation for Medical Education and Research, published by Elsevier Incorporated. All rights are reserved, including those for text and data mining, AI training, and similar technologies.